بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Thank you, Professor Saad. It's a great honor for me to be a moderator in this exceptional session with mega learning platform. As you said before, we are all of us we are learning and engaging and connecting with the distinguished speaker and distinguished scientists in this platform. It's a great honor for me today to introduce two of eminent speakers all over the world. And as you see here, we are engaging together and connecting from east to west, from the far west to the far east. The mega learning platform bringing science from everywhere. I hope for all the attendees to enjoy and to get benefit from this session. Especially we have the well-known Professor Doyle, John Doyle. Professor John Doyle is with the Department of General Anesthesiology, Cleveland Clinic, as well as Professor of Anesthesiology at the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. He received his MD degree in '82 and his PhD degree in Biomedical Engineering in '86, both from the University of Toronto. He received his Canadian board certification in anesthesia in '86 and his American certification in '89. Dr. Doyle has a long-standing interest in ENT anesthesia and difficult airway management, as well as an interest in the use of technology in medicine. His research has been supported by a number of funding agencies, and he holds positions on a number of editorial boards. He is past president of both the Society for Airway Management and the Society for Technology in Anesthesia. And by the way, we will meet Professor Doyle frequently to give us from his experience in the basics of the anesthesia and in the basics of the medicine. So please, all the attendees, welcome, and we are listening now to Professor John Doyle, and the floor is yours. So please go ahead.
Thank you, Professor Essa, for the kind introduction. My talk today is an abbreviated history of anesthesia, and I would remind everybody that I'm hoping to present a companion to this talk on the 24th of October, dealing with the history of clinical airway management. But today's presentation is an abbreviated history of anesthesia. And I'm going to move the slides along here. A good place to begin with understanding the history of anesthesia is with the Wood Library Museum of Anesthesiology in the United States. And if you go to the website shown on the top of this slide, you can get information about the history of anesthesia that you will find to be delightful, including some videos and other information. And indeed, a lot of the information presented in this presentation comes from this source. So let's start from the very beginning. Before the days of anesthesia, surgery was very traumatic. Here's an example of a person who's getting a leg amputated, presumably for gangrene. And you can see that you would have a number of strong, burly men holding the patient down, and then the amputation would be carried out as quickly as possible with little regard to anesthesia or pain, because there was few in the way of options, although we'll talk about some of them in a minute. And of course, no regard for the problem of sepsis that didn't come along until Lister, who I will talk about in a few minutes. Here's some depictions of agony endured in operations before the advent of anesthesia. On the left, a caricature and in the middle, in the right, some images that showed how challenging surgery was in the days before anesthesia. For example, removing a skin lesion or doing neurosurgery to reduce intracranial pressure. These are all things that were terribly agonizing in the days before anesthesia. It's not as if there was nothing that was available. For example, about 6,000 years ago, we had Sumerian artifacts depicting opium in the form of the poppy, and opium is available in a variety of formats. The sedative, analgesic, and euphoric effects of opioids have been known since antiquity. And in fact, it's described in Homer's Odyssey and well known to physicians by the time of Hippocrates, which was around 400 before the Common Era, BCE. However, it's also known early on in history that opioids can produce life-threatening respiratory depression, limiting their utility and, of course, their safety. Here is a comment from Homer's Odyssey. She, Zeus's daughter Helen, cast a drug into the wine, of which they drank to lull all pain and anger and bring forgetfulness of every sorrow. And of course, a variety of opium products were produced in the days before anesthesia, or even in the days when anesthesia was early. We have opium tablets, and we had opium pills. One popular form of opium was called laudanum, and this was a combination of alcohol, and typically 1 fluid ounce of laudanum contained 45.5 grains of opium and 40% alcohol. It contains the equivalent of around 10 milligrams of morphine per milliliter of solution. And of course, it's quite potent and potentially poisonous. They use the units of grains. We no longer use that, but 1 grain is 65 milligrams. Of course, we do know that opium is addictive. And here we see an opium parlor or an opium den where people would come and they would smoke opium all day. And of course, this is very dysfunctional for society, having these people getting addicted to opium. And this led to an interesting historical development. The Opium Wars were 2 wars fought in the mid-1800s that were the climax of a long dispute between Britain and China concerning the opium trade. The Chinese emperor had banned opium in China due to its harmful effects on Chinese citizens, as you just saw, the opium dens. The British Empire, however, saw opium as a profitable good for commercial trade, as its import would help balance Britain's huge trade deficit with China. The Opium Wars and the unequal treaties signed afterwards led in part to the downfall of the Chinese Empire, as many countries followed Britain and forced more treaties to increase trade with China. So it looks like the British were one of the first national drug dealers, and it's sort of a stain on their international reputation. Here is a battle scene from the First Opium War, 1839 to 1842. You will recognize the year 1842 as especially important in the history of anesthesia because this was the first use of ether anesthesia in the United States. Now, other products were available in antiquity. Cannabis was noted to be a product that would sedate surgical patients to provide euphoria. And as you may know, the CB1 and CB2 receptors are the cannabinoid receptors in investigation at the moment. The CB2 receptors have anti-inflammatory properties that are potentially useful and the subject of ongoing studies. The CB1 receptors, when activated, are, of course, are the ones that produce the high associated with cannabis. Other things that have been described in history, here is general anesthetic that was a combination of wine and herbal mixtures used in around the year 100 to 200. And not much is known about the composition of the herbal mixture, but it has been used in some ways as a sedative or an anesthetic. Very little is known about it, except that there is this woodcut describing it. Later on, we had opium made into morphine. The pharmacist Friedrich Serturner isolated morphine from opium. And that changed the history of anesthesia in important ways because it was a very effective analgesic named after Morpheus, the god of dreams. Another product associated with opium and morphine is heroin. What's interesting about this, this is an advertisement coming out in 1901, 120 years ago, used as a cough elixir. It wasn't really that well understood at the time that it was highly addictive. It was known to be a great analgesic, but not to be known to be an addictive product. And it was used primarily in the early days for the relief of coughs. In the 1800s, nitrous oxide was used for anesthesia. It was discovered by the English chemist Priestley in 1772, and another English chemist, Humphrey Davy, named it nitrous oxide and showed its physiologic effect. And as the physiologic effects became more apparent, its use became more ubiquitous. There was an exhibition of the laughing gas that was sometimes carried out in various places in the United States. Here is an example of somebody inhaling the nitrous oxide, and this would cause bizarre behavior such as dancing, acting, jumping, laughing, and so on. This did not contain any oxygen. It was just pure nitrous oxide, and so the possibility of inhaling an hypoxic gas mixture was something that was a concern, not appreciated at the times. Here is an example of an exhibition of nitrous oxide, and showing that they would make this gas available to anyone who wanted to breathe it, and they would watch their behavior. It says here, men will be invited from the audience to protect those under the influence of the gas from injuring or themselves or others, and they would be expected to laugh, sing, dance, speak, or fight. And of course, you may recognize this as the excitatory phase of anesthesia, stage 2 of anesthesia, which we'll have a chance to talk about when we talk about Goodell. So Horus Wells was one of the individuals. He was a dentist who popularized nitrous oxide as an adjunct to providing dental anesthesia. And here's the apparatus shown on the right that was sometimes used, but it didn't work as well as he had hoped. And he ended up getting very despondent over the fact that nitrous oxide wasn't as well accepted as he had hoped. He committed suicide, and in the upper left, you can see an artist's depiction of his suicide, and on the right side, the description of his life carried out in the Boston Medical Journal, 1925. Now you would recognize the Boston Medical Journal as the New England Journal of Medicine. Another key player that came along at the time was Crawford Long. He etherized a man called James Venable for removal of neck cysts in 1842, and he would become the first anesthesiologist on a US postage stamp and the inspiration for the National Doctors' Day held every day in March 30th in the United States. So this was Georgia's tribute from the state of Georgia where he came from. And here is a life-size replica of the life-size statue held in his honor. About 4 years later, William Morton, a Boston dentist, demonstrated the use of ether during surgery. Of interest, people did not know about Crawford's Long development in 1842, some 4 years earlier, because Crawford Long had not publicized the development of ether anesthesia. What happened is that members in the community, particularly the church elders, saw what he was doing and told him that it was against God's wishes to give anesthesia. And so Crawford Long said, "Oh, I'm sorry," and stopped giving anesthesia and didn't popularize it. Meanwhile, in 1846, Morton demonstrated it to a large group of people in the Massachusetts General Hospital, and word spread around the world. And he initially got a lot of the credit for ether anesthesia, and Crawford Long wasn't well appreciated until years later. There was a description of the insensibility during surgical operations produced by inhalation of ether. This is dated Wednesday, November 18th, 1846. This is only 1 month after it was demonstrated in the Ether Dome. This is amazingly fast for publication to come out only 1 month after the event. And the details are provided here. One way of giving ether was through an ether mask or a Schimmelbusch mask. That's one variation of it. And the mask would go over the face, and then you would pour the ether in a very careful way. But the original ether anesthesia carried out by Morton was this sponge soaked in ether in this particular gas appliance shown here. Here is it in more detail, the original ether inhaler used by the ether dome. And the idea here is that they would have a valve that you could open and close in synchrony with the patient's respirations, and they would get the ether from the soaked sponge. So mask anesthesia, the use of inhalers and drop mask techniques were all equally capable of producing an unconscious patient, but offered no airway protection or control against apnea or emesis. Both were serious problems and remain problems to this day, but now we have way more techniques to mitigate against these problems, particularly for apnea, where we can intubate and ventilate, or emesis, where we ensure that the patient has an empty stomach beforehand, or we do a rapid sequence induction, and we use antiemetic medications. Particularly ether was very emetogenic, and emesis was a problem all those years. On the left, you can see some ether products in the Schimmelbusch mask, and on the right, you can see how the mask was applied over a face with this gauze, and then the ether would be poured over it in a systematic way. Here is an advertisement for ether anesthesia from Mallinckrodt. It says here, ether is by far the safest for children. As an alternative to ether that was sometimes used was chloroform, that we'll talk about in a little while. But clinically, they knew that ether was safest because it didn't cause the respiratory depression and the occasional cardiac arrest associated with chloroform anesthesia. However, an important thing to emphasize is that ether was highly flammable. That eliminates the use of diathermy. You had to go and use ligatures for all the vessels, and that complicated the surgical procedure. One of the things that became apparent early on is that patient monitoring was a challenge. We know now today that patient monitoring and patient management involves things you measure, like blood pressure, things you observe, like the pupils, planning to avoid trouble, like planning your anesthetic induction, inferring trouble, and how to get out of trouble. But in those days, not all of these things were well established. In the past, monitoring of the patient involved visual monitoring of respiration and overall clinical appearance, the Goodell anesthetic stages of ether anesthesia that I'll go through in a minute, finger on the pulse, and sometimes, and only sometimes, blood pressure. Goodell, around 100 years ago, described these stages of ether anesthesia, stage 1 being analgesia, stage 2 being the excitement phase that you would see when people gave nitrous oxide on the stage. And in addition, they had a thing called ether frolics, where they would give ether on the stage and they would go into the excitement phase and behave in bizarre manners. In fact, it was observed by Crawford Long that there was a patient who injured himself in an ether stupor in one of these ether frolics, and yet, despite bleeding from his leg, didn't seem to mind the pain. And this led Crawford Long to think that ether might be useful as an anesthetic technique, and that was the seed that got him going. Going on with the stages of ether anesthesia, we have 4 surgical planes for stage 3 surgical anesthesia, and stage 4 imminent death involved apnea, hypotension, which of course we recognize today, and we treat with airway management and sometimes with vasopressors. Now, monitoring in the past, they still had a finger on the pulse, as you can see here, where they were taking a lesion off this patient's neck in this description of ether anesthesia in 1846. Another important development that occurred not too long after was the idea of sepsis. And on the left, you can see a man providing ether anesthesia, and you can see Lister in the center with a scalpel and his assistant spraying carbolic acid over the surgical field as a method of antisepsis. So Lister made the foundations for surgical antisepsis, and that in combination with anesthesia made modern surgery possible. So Lister, the founder of the principles of antisepsis in surgery, worked in Scotland and the UK, 1850s to 1890s. What's interesting is that he protested against palpation of the pulse as a most serious mistake. He says, as a general rule, the safety of the patient will be most promoted by disregarding the pulse altogether so that the attention may be devoted exclusively to breathing. Basically, he taught that as long as the patient was breathing all right, everything else took care of itself under ether anesthesia. Now we are more sophisticated than that, but it shows you the importance of respiratory monitoring in anesthesia. Lister's instructions to the senior students who carried out his anesthetics was that they strictly carry out certain simple instructions, among which was never touching the pulse in order that their attention may not be distracted from the respiration. He repeatedly emphasized the importance of airway management, urged the drawing out of the tongue. Remember, at this point, the Goodell airway devices were not invented. There was no oropharyngeal airway, for example, and expressed belief that the services of special anesthetists were unnecessary if simple routines were followed in the administration of chloroform. Of course, chloroform, we found out, is fairly dangerous. It causes unexpected cardiac irritability and death, often in the form of ventricular fibrillation. So Dr. Lister gave little attention to monitoring beyond observation of the adequacy of respirations and whether or not the patient responded to surgical stimulation. Our attitudes have changed now quite a bit, but before we go on to that, here's an interesting side note about Listerine. The mouthwash known Listerine, very popular in the United States, was carried out in honor of his contributions, but many, many years after Lister's death. So Lister never got to know about Listerine. An important man in anesthetic monitoring is this man, Harvey Cushing, the neurosurgeon. He's not just a famous neurosurgeon, but the father of anesthetic monitoring. He invented and popularized the anesthetic chart, recorded both blood pressure and heart rate, and emphasized the relationship between vital signs and neurosurgical events, that is, increased intracranial pressure leading to hypertension and bradycardia. The article that he used as the basis for his blood pressure monitoring came from Torino in Italy, 1896, Rivarocchi's development of the sphygmomanometer. And he described this some years later in the Boston Medical and Surgical Journal, 1903, routine determinations of arterial tension. And we've been measuring blood pressure in the operating room ever since. So he brought the sphygmomanometer into the operating room, but it's interesting that his initiatives were not accepted easily. And opponents to the newer devices to measure temperature, blood, pulse rate, blood pressure, and the auscultation of the heart were castigated, for example, by an editorial in the British Medical Journal claiming that by such methods we pauperize our senses and weaken clinical acuity. The idea here is that you should be so good at clinical observation that instrumentation is not needed. We now know that this attitude is wrong and that modern instrumentation is life-saving, but it wasn't always appreciated that this was the case. In fact, 90 years after this article emphasizing that Cushing's initiatives were unnecessary, 90 years later, we have a publication referring to capnographic monitoring that everyone accepts now. It says, in almost 30 years of anesthesia practice, I've yet to encounter a case in which the outcome could have been changed by the presence of such a monitor. And another guy writing, we should recognize and acknowledge that the true set value of monitoring has not been validated, and slavish obedience to sets of standards, whether imposed by professional societies or legal bodies, is neither in the interests of anesthetists nor their patients. We now know, of course, that such an approach is completely wrong. And certainly in the United States, we know that the safety of anesthesia has increased enormously, both in terms of the statistics involved, as well as the reduction in medical malpractice insurance premiums. Let's move on now to talk about Joseph Clover. He was another innovator in anesthesia, and he was administering here chloroform through this bag that you can see over his shoulder. And the thing about him is that he developed the first apparatus to provide chloroform in controlled concentrations, but he also described the all-important jaw thrust technique for opening the airway. and performed surgical airway with a metal cannula, as shown, in the first cricothyroidotomy by an anesthesia provider. So he was a pioneer both in the use of chloroform in controlled concentrations, as well as clinical airway management, both non-invasively with the jaw thrust maneuver and invasively with the surgical airway. Since the time of ether, a variety of other anesthetic agents have become available. Here is the drug vinyl ether, which many of you have not heard about and is no longer available for clinical use. Another drug that's especially interesting is cyclopropane. We'll learn about cyclopropane when we talk about the use of Karari, because that was what Howard Griffiths used in his demonstration of the use of Karari. Here is an advertisement from Squibb and Sons, cyclopropane anesthesia in abdominal surgery. The thing about cyclopropane, it is highly, highly explosive. And for example, here is an article from 1937, Mechanics and Handicraft, and it says, murdered on the operating table, blast kills patient on operating table, anesthetic in lungs explodes during cautery on neck in Johns Hopkins Hospital. So cautery or diathermy exploded this patient who had a combination of cyclopropane as well as oxygen. So that can be highly dangerous. In those days, you did not use cautery, you did not use diathermy. You had to tie things off with sutures. You had to ligate everything. Here's an example of an operating room in Wyoming, United States, 1910. And you can see the ether being put over the face mask here. And you can see not everybody covers up their face with surgical masks. That's very different from the way things are done today. Here in 1920, you can see anesthesia and surgery carried out. Again, no masks on their face, and you can see the ether inhaler used with a nurse anesthetist on the top. And what's strange to see is the patient's arm just dangling there, which we would never allow today. In the 1950s, we got introduced to halothane. And because it was non-flammable, non-explosive, and non-irritating to the airways, and provided rapid induction of anesthesia compared to ether, it became very, very popular. And this was one of the drugs I was brought up on and when I was introduced to anesthesia in 1983. Here are a variety of drugs that are now available. Ethrain or enflurane, not commonly available anymore. Halothane, not shown in this description. And most commonly, we will use sevoflurane or desflurane in our anesthetic practice, but sevoflurane is our go-to drug most of the time. Another drug not commonly available that I enjoyed in my very first year of anesthesia was Altheasen. It's a 3-to-1 mixture of 2 neurosteroids, but it was dissolved in cremophor, and that resulted in anaphylaxis more frequently than was acceptable, and it was subsequently withdrawn from the market. What's interesting is that propofol, when it was originally produced, was also dissolved in cremophor, but recognizing that that was dangerous because of the anaphylactoid reactions that would occur, they changed it to be mixed in intralipid, and that made it successful. So Altheasen, a very nice drug, like in many respects like propofol, but no longer available on the market. Now, another drug with a fascinating story is Karari. And here is the history of Karari in a nutshell. Claude Bernard identified the site of actions of Karari as the myoneural junction in 1842. And that was 100 years before the first use of anesthesia. And you can see on the left, the plant that Karari comes from. And on the right, you can see an Aboriginal man with a blowpipe that would send a Karari dart into an animal, and that would weaken the animal in such a way that you could run after them and then kill them. It didn't usually kill the animal right up front. What it would do was weaken them to the point where you could easily capture them or kill them. A highlight in the story of Karari is the 1938 Gill, Ecuador exposition, where Richard Gill took a trip in 1938 to Ecuador to identify this plant that in folklore was associated with allowing you to capture animals as a product that you would put on the tip of an arrow and blow in a blowpipe. So he went down to Ecuador, and the story here from Anesthesiology 1842 is available for those people that would like additional details. And a whole book on this is called Arrows of Mercy, which was written in the 1960s by a Canadian called Philip Smith. And of interest, I had a chance to actually visit Philip Smith a few years before his death when I lived in Toronto, and he told me about the story of the writing of this book. In 1942, 100 years after the first use of ether anesthesia, was the first successful trial of Karari in anesthesia using cyclopropane, the explosive anesthetic performed by Harold Griffith at the Montreal Homeopathic Hospital. And here he describes some details about how this was done. Here is some more details from Anesthesiology 1942, the use of Karari in general anesthesia by Harold Griffith and his resident, Dr. Johnson. So those who want more details, there's articles that are described. Here are some interesting things that he would point out. On the bottom left, he said, one young man undergoing a cholecystotomy for very severe acute hemorrhagic pancreatitis was given open ether with most unsatisfactory abdominal relaxation. So he was given 5 cc's of introcostin, and immediate relaxation ensued, but there was also cessation of respiration. An endotracheal tube was introduced and anesthesia continued. And he goes, the drug prostigmine, which is allied chemically to physostigmine, apparently bears the closest resemblance to a true physiologic antidote of Karari. In those days, it wasn't fully appreciated that you should reverse all patients who get neuromuscular blocking drugs. In his ongoing description, this from Anesthesiology, but this from another author, that is Whitaker, coming from Cleveland, Ohio. He writes, respiratory depression occasionally occurred, and that is interesting that they were able to do Karari anesthesia under patients breathing spontaneously. But perhaps what's more interesting is the bottom part, which says another patient was given 20 milligrams of Karari following administration of 400 cc's of a 5% solution of intravenous ether. So intravenous ether was an anesthetic technique used for IV anesthesia. Rather than giving it by inhalation, which is not as reliable as intravenous, you could give a 5% solution of ether intravenously. Who would have thought? Well, the thing about Karari is that it resulted in a number of deaths because it wasn't fully appreciated that neuromuscular blocking drugs should be reversed. In this study of almost 600,000 anesthetics in 10 institutions ending in 1952, after the onset of neuromuscular blocking drugs in Karari, Beecher and Todd concluded that the use of Karari resulted in a 6-fold increase of anesthesia-related deaths in this very important study carried out at Harvard Medical School. Patients were usually breathing spontaneously despite getting muscle relaxants. Fortunately, the diaphragm is among the last to be paralyzed by Karari. The importance of reversal agents, not initially appreciated, and no means of formally monitoring the degree of muscular blockade was available. Now, that kind of brings an end to our history of anesthesia, although there's so many more recent developments I would like to talk about. And in fact, I will be talking about the history of airway management, if all goes well, on October 24th at this same forum. But many other important drug developments have occurred that are more recent and therefore not really part of the anesthesia history. Propofol, introduced in the 1990s, advanced opioids like remifentanil, sufentanil, dexmedetomidine, introduced in recent years, and sugammadex, introduced in recent years as well. And these will be the subject of discussions for future historians. Important technical developments like the importance of pulse oximetry, capnography, and anesthetic keeping systems are all part of the technical history of anesthesia, but these are more recent developments. So with that, I would like to thank everybody for their time, and I look forward to all of your questions. Thank you very much.
Thank you so much, Professor Doyle, for this interesting lecture. And I think for all of us who are going to present any presentations, they need some to hit light about history. We have some of questions for you, of course. And before these questions, I'd like only to comment about your presentation because you didn't mention the role of the ancient Egyptians in the history of the anesthesia. And I think it is recorded on their temples. And I heard that the first operation had been done in the ancient Egyptians as trepanation and of the hairs and some of the alcohols or datura or something like this from the planets. This is number one. We have some of the questions from our colleague Muhammad Suleiman, and he is focused also about what I said just now about the ancient Egyptians. And we have also a history of Arabs, and this we have in our department in Saudi Arabia in King Saud University, our Professor Muhammad Takruri, he had a book about this development of anesthesia and history of anesthesia in the Arab era. Dr. Muhammad Sulaiman also, he asked one of interested question, and he said still some poor countries use old unsafe ways of anesthesia. How can we decrease the gap between different countries nowadays so that all have the chance of welfare of safe standard practice of up-to-date anesthesia? Thank you.
Okay, well, thank you for those comments. Regarding the history of anesthesia from an Egyptian and Arabic point of view, I have got that citation and added it to my list of activities because I would like to add material to the next opportunity reflecting that, because there is a lot of information that I would like to add. This also includes information from India and from China, which has their own history of anesthesia. The second question is, what do we do about the gap between different countries for the provision of anesthesia? And that reminds me of a story when I was at a conference, and I was in Venezuela, and there was a speaker from America who said that no operating room should be without fiber optic intubation. It should be a crime. And one of the people from the audience said, yes, sir, and poverty should be a crime as well. You have to work with the resources that are available. There are efforts going on for technology appropriate developments for underdeveloped countries. And that includes using techniques that may be different from those used in the West, but are very inexpensive and relatively safe. One of those, for example, could be the use of ketamine. Works very well, and in the right settings is very inexpensive and tends not to get you into trouble the way some of the other drugs are. So the World Federation of Anesthesia is interested in exactly this problem, making resources available. And an example is pulse oximetry, which is now relatively inexpensive and can be purchased for under $50 for the simple models that go on your finger. Nevertheless, eliminating poverty is the #1 thing you can do.
Thank you, Professor Doyle. I think it is very difficult to cover the history of the anesthesia in one lecture because we have a lot of issues in the history. For example, we have a lot of improvement in the history of the anesthesia until we reach nowadays for the era of ultrasound. regional, and it has a great evolution in the development and in the managing of the such risk patients. There is a history in the improvement of the drugs and history in the improvement of the technique as well as in monitoring. I know that your time is limited and you have some of commitments. So thank you so much for this exceptional and amazing lecture. And we hope all the time to be with us for giving us basics for anesthesia. Thank you so much.
Okay, and I hope to present the history of airway management, a companion to this talk on the 24th of October. And thank you everyone for your lovely attention. Thank you again.
Excellent.